Good morning. Thanks very much for the invitation to speak today. It's nice to sort of get back to reconnect, I suppose, with my roots in St. John of God's. It's where I started out my journey as a psychiatrist, back training a bit over 30 years ago now, back in the mid-1990s. So it's nice to be back. So as Fiona said, I'm a child and adolescent psychiatrist, but I have this sort of unusual job where I'm working exclusively with teenagers with substance use problems. And that's really across, at this point, all of South Dublin and down into Wicklow are, I suppose, the areas I have primary responsibility for. What I was going to touch on is a little bit about adolescents, their brains and how they're developing and changing, but also, I suppose, the other tasks of adolescence. Remind ourselves again, what is it that draws young people towards substance use in the first place? Remind ourselves, I suppose, why it is we as adults aren't very keen on them heading down that path. A little bit about treatment, and talk a bit about the new dual diagnosis model of care, which is sort of being rolled out sort of as we speak last year or two, and hopefully for the next few years. So the human brain, we know, doesn't fully mature until the mid-20s. And it develops in a bottom to top, back to front type manner. Colin touched on the dopaminergic system and the frontal cortex and so on. So the prefrontal cortex is the last bit of the human brain to fully mature. And in terms of trying to think about the brain and what it does, you know, I'm constantly looking for analogies or things I can relate to. I find the brain a little bit abstract and all its really complex functioning. But for me, the prefrontal cortex is a bit like the brain's braking system. It's the bit of the brain that vets impulses that are perhaps arriving in from up from the limbic system, the more primitive parts of the brain. It vets those impulses and says yes to some and no to others. And that's the last bit of the human brain to fully develop. And it's a big part of the reason why I think teenagers can make decisions that us as adults look objectively rather unwise and poor. It's because partly they're biologically programmed to go forward and they're not as good at stopping. Aristotle said 2,500 years ago that youth are heated by nature as drunken men by wine. And he didn't have access to that slide, but that's really what the slide is saying. And that's a rather biological way of thinking about teenagers. And while the thought's in my head, I'll share it with you, which is just the neurotransmitter system that seems to guide that delicate process of brain remodeling across the adolescent years. A key neurotransmitter system there is the endocannabinoid system. So we all have, you know, CB1 receptors in our brains. Anandamide is the natural neurotransmitter that acts at that receptor. And it plays a significant role in terms of the new neural connections that are being established across adolescence, the ones that have been pruned away, and the myelination process that occurs as part of that. And it's part of the reason, again, why I think cannabis and external substances that act at that same receptor system maybe have more potential to do damage to young brains. That's all a very biological view of teenagers and their journey. It's also worth thinking about the journey in more psychosocial terms. I think your job as a 10-year-old is to become an adult, an independent adult, to pick up all the complex social skills that we as adults require in terms of building and maintaining friendships, loving relationships, functioning in the working world, having our own family and so on. And you've got to acquire a lot of social skills between the ages of 10 and 25 to allow you take on those tasks. So I'm inclined to think about teenagers as apprentice adults. And thinking about them as apprentices makes it a little bit clearer what the role is of adults around them, principally their parents, I suppose, but teachers, the wider community, relatives, and so on. Our job is to guide these apprentices on their journey. I guess like any apprentice, they're going to vary, you know, that most apprentices are grand. I'm involved in training doctors. I view them as apprentice doctors. And most of them are good. They're good at judging where they're at on their own journey, and it's just it's a bit of a steering job. But sometimes you get apprentices who sort of overestimate their ability, and they put themselves into situations that maybe are slightly outside their current level of competence, and they're the ones who don't do so well. And within our adolescent apprentices, that's the psychological profile, I suppose, that I'm perhaps a little bit more likely to see. Colin has already touched on this as well. This is, looking at the brains of people with addictions, particularly brains of people who are using chemicals and that they have a chemical addiction to alcohol or other drugs. Nora Volkow, who's head of the National Institute of Drug Abuse in the United States, wrote this, I suppose for me it's the neatest definition of addiction, a pathology of motivation and choice. And what that means is that, due to repeated past drug use, a person's brain has been changed to amplify the motivation to continue engaging in the behavior. Their limbic system has sort of been a little bit hijacked by all the past drug use. So there's an excessive drive to engage in the behavior, which people might subjectively experience or refer to as cravings. And there's simultaneously a reduced ability of the prefrontal cortex, the braking system, to resist that impulse. That's the ability to exert choice. So motivation to engage in the behavior is artificially amplified, and the ability to exert choice has been compromised or impaired. But of course, it's not the loss of motivation and choice. It's just the pathology of it. There's an impairment of it. Otherwise, people wouldn't recover. And I suppose there is pretty good evidence, again, as Colin alluded to, that some people can arrive into their substance use journey with a brain that's already a little bit wired in that direction anyway, a little bit more prone to seek pleasure, I suppose, and a little bit less able to weigh up pros and cons in a prudent manner to exert control over those impulses. And it can become a bit of a vicious circle. When we ask young people, why do you use drugs? They give a complex range of reasons. And the data on this slide, I suppose, is a little bit busy, but it's from across Europe. Young people asked, have you used the drug A, B, C? If you have, what contributed to your decision? And so for the two, I focus on the drugs, I suppose, that concern me most at the moment for youth in Ireland, which are cocaine and cannabis. And the most common reason for each of them is for fun. People use drugs to socialize, to enhance usually a social experience. There's an unhelpful narrative that sort of says all drug use has its origins in sort of people trying to relieve pain or trauma. Across the population, I certainly don't believe that. And that's not what young people say. It's generally pretty happy, content people who are just trying to make a good night better. That's what's in their own head. Where that deviates a little bit, certainly in terms of the two drugs I focus on here, is for cannabis. And there's a lot of people report using cannabis for what we'd call maybe more self-medication reasons. So there's, we tend to drive the motivations to drug use into hedonic ones, which are pleasure-seeking, versus coping strategies, which are about maybe addressing some sort of physical or psychological distress or pain. But certainly for cannabis, to improve sleep, reduce stress, and to manage their depression and anxiety, very frustratingly, is a common self-reported reason for cannabis use. This is data from the recent survey conducted in third-level institutions in Ireland. It looks at a broader range of drugs, asks young people why you use these drugs, and for pretty much all drugs, again, the most common reason is just for fun. For cannabis, you see there again, there's a lot of self-reporting it, just as a way of relaxing. But there's very, very few reporting it, any of these drugs as a primarily undertaken to manage emotional distress. There's also data for 16-year-olds in Ireland from the SPAD survey, it's I suppose close to 1 in 5 say that they drink alcohol, certainly some of the time, to help them manage, feeling depressed or nervous. And also down the bottom there, sort of equally, sort of frustratingly, we see a lot of young people at the age of 16, 15, 16 who are drinking so as not to feel left out, and in order to be liked by others. And they're motivations that should concern us, I guess, as a society. So, I've been doing an awful lot of talks over the last few weeks, and I'm trying to remember why again I put this slide in. Okay, so I think it goes back to the motivations for alcohol use, and I suppose it links into some of my concerns about the motivations for other drug use. But we know that some people use alcohol actually as a method of managing pain. They might have arthritis or whatever, and they'll drink to help them manage that. And I suppose the key point of this slide is that even though there is good actually objective evidence that when you give sort of people alcohol intravenously in conditions where they don't know what they're receiving, there is evidence that it does actually reduce pain. It is genuinely an analgesic medicine. But of course, we would never use it as a medicine because it has all sorts of dreadful risks associated with it. It has the addictive potential and all the physical damage it can cause. And I guess the last time I used that slide was while I was talking about the great lie of medical cannabis, because the evidence actually that cannabis is effective for pain isn't nearly as impressive as this evidence for alcohol. But sadly, the narrative within society is that, there's some evidence that it works for pain, therefore it's a medicine, therefore we should be prescribing it to people. Well, obviously, a bit like alcohol, we certainly shouldn't be prescribing an addictive psychotogenic drug to people to manage pain, in the case of cannabis or alcohol. And then sticking with cannabis, one of the issues we know with cannabis for across the population where people use it on a daily basis, they can actually get dependence and they can get withdrawals. So again, sort of when I was doing my training in psychiatry 30 years ago, I would have believed there was no such thing as withdrawals from cannabis. There now is a withdrawal syndrome that is well described. It's not nearly as dramatic as opioid or alcohol withdrawals. Indeed, there's very few physical symptoms, although people can get sort of abdominal cramps. The majority of symptoms are psychological. And the most prominent is irritability, aggression, snappiness, I suppose. And that's certainly what parents will describe where they've got a cannabis-dependent teenager at home. There's also, I suppose, disturbed sleep and depressed mood. So going back to the motivations why young people say they're using cannabis, it's to help their sleep, to manage their depression, and to make them feel less stressed. But cannabis withdrawals actually can cause all these problems. So I worry that a lot of young people, particularly if they're using cannabis on a daily basis, are justifying their use in order to manage symptoms that are actually withdrawal symptoms. A bit like a drinker sort of saying, a daily drinker sort of saying, I drink alcohol in the morning to manage my sweats and shakiness in the morning. We'd recognise that for what it is, but again, we're less good at recognising perhaps the self-medication with cannabis for similar reasons. The spinner, the information that young people are consuming about cannabis, sadly, is extremely positive. It's broadly presenting it as not just that it's pretty harmless. There's an awful lot of information out there saying that it's actually therapeutic and beneficial. And unfortunately, young people who hold that belief in its sort of health or therapeutic benefits are the ones then who are most likely to use most heavily and most likely to develop an addiction issue. And I would certainly be a strong believer that we need to counter the industry-driven social media messaging that's been targeted at young people, and government needs to do a little bit more to step into this conversation to give young people the facts about the dangers and risks of this drug. The reason I'm talking about cannabis so much is that 70% of my referrals in under 18s are cannabis is the main drug. Other things that young people and adults indeed need to be more aware of is that, okay, we haven't got a properly delineated and described fetal or cannabinoid or fetal cannabis spectrum disorder described as yet, but my guess is it'll just be a short number of years before we do. There is certainly pretty certain evidence that cannabis use by mums during pregnancy is associated with premature birth, smaller birth weight and so on, but there's also growing evidence of an excess of deviations in normal development of children who have that sort of exposure in utero. As for the link between cannabis and psychosis, I think it's now so overwhelming. I think any reasonable person would have to accept that there's a causal relationship. Obviously, the vast majority of young people who smoke cannabis regularly don't develop psychosis. It just increases the risk. An average 15-year-old might have a 1% risk of developing an illness like schizophrenia as they journey through life. If they smoke a lot of cannabis at the age of 14, 15, that risk might go from 1% up to 3 or 4%. Still 96, 97% won't develop a psychotic illness. Something that sort of a new challenge that I think frustrated both Colin and myself in the last couple of years was the fact that now drugs are being sold in Irish shops again. HHC was being sold up until a few months ago, and it sort of quickly began emerging as part of a pattern of polysubstance use in the teenagers we were seeing in adolescent addiction services. It actually became the second most common drug, driving demand for addiction treatment during the first half of this year. Also in our adult mental health services, they began seeing increasing numbers of presentations of young people, and sometimes not so young, who became psychotic in the context of HHC use. And again, it became the second most common drug precipitating psychotic episodes in Ireland, second only to cannabis, during the first half of this year as well. When I meet colleagues who are working in sort of more mainstream psychiatry, both working with young adults and indeed working with adolescents, occasionally a diagnosis will crop up of someone having a drug-induced psychosis, and there's often a tendency to be a little bit relieved when we convince ourselves that a young person has a drug-induced psychosis, that they'll be grand if we can just get them to stop using the drugs. And I worry that that's a slightly optimistic assessment of the real risks that those young people face. So what this slide looks at are people across the age span, broken up by age and gender, who presented to emergency departments in the States, and then it divides up those emergency department presentations to those that involved drug use, or if they involve drugs, do they involve cannabis, and if they involve drugs, do they involve psychosis, and so on. And what you see is and it looks at the proportion of the likelihood that the person who had presented was going to reattend within 3 years with a schizophrenia spectrum disorder. So it looks at the conversion rate, the likelihood that these presentations would sort of evolve into schizophrenia within a 3-year period. So you see on the left-hand side there, if there's no drugs involved, there's no psychosis involved, the likelihood of that person developing schizophrenia was 1 in 1,000 about. But the worrying bit of this graph is the top right-hand corner, which is about 40% of the young males who presented with a cannabis-induced psychosis had a diagnosis, schizophreniform diagnosis, within 3 years. So that's certainly the figure I hold in my head. For me, it's a 50-50 toss-up. If you've got, particularly if they're male, particularly if they're in that sort of late teens, very early 20s age range, it's 50-50 whether or not this evolves into or actually is schizophrenia at first presentation. Yeah, there may be some drug use, and it may have been caused by the cannabis use, but that there isn't, I guess, necessarily that optimism that if we take the cannabis out of the equation, all is going to work out well. So as I said, part of the reason why cannabis might be having some of these potential adverse impacts is because of its role in this brain remodeling that's occurring across the adolescent years, and maybe exposure to an exogenous cannabis agonist just sort of nudges that delicate developmental trajectory down a slightly different pathway that mightn't manifest itself for years, but ultimately can lead to a particularly negative outcome. And I guess that shouldn't surprise us. It shouldn't surprise us that what we do with our brains and to our brains has an impact on our brains, because there's endless examples across the environmental insults on the human body of how the environment shapes us, in maybe in good ways, maybe in not so good ways. Sometimes temporary, sometimes reversible, not always. So the fact that our brains can be influenced and changed by a period of drug use or drink shouldn't come as a shock, and that's maybe particularly likely to be possible during adolescent years. Again, when the brain is more plastic and changing anyway, again, shouldn't surprise us. Robin Murray has been wonderfully vocal about cannabis, I guess, and his concerns regarding it over the last decade or more. He seems very convinced it's causally related to the development of schizophrenia. And as a man who's no axe to grind with cannabis or drugs generally, who spent his lifetime trying to figure out what causes schizophrenia, the fact that he is so clear on that now is useful. And his view of what's happening in North America is that, you know, that they've embarked on this crazy experiment with the brains of their own children, and he didn't anticipate it's going to work out terribly well. And lots of other medical groups seem to be buying into that concern about liberalising cannabis or wider drug policy. The Australian Medical Association, the American Medical Association, the Standing Committee on European Doctors have all issued statements in the last couple of years indicating their belief that legalising drugs like cannabis just makes things worse from a public health perspective. When you look at the data from Canada, this is sort of general population survey data, asking people to use cannabis. If you do, then exploring for symptoms indicating a possible cannabis use disorder or cannabis dependence, self-reported symptoms. You see about sort of 6 or 7% of the population were reporting sort of a somewhat problematic pattern of cannabis use up until around 2013-14. They began really liberalising their medical cannabis laws in 2014-15 to basically mean that any patient could get cannabis from almost any health professional for any reason at that point. So it really was de facto legalisation, a bit of a nod and a wink, and you'd leave with your recommendation, which you take off down to the dispensary and you get your little bag of weed as medicine. Certainly against that background, the proportion of Canadians self-reporting problematic cannabis use began to nudge upwards. It moved from about 6% up to about 10%. And then with full legalisation in 2018, that's gone up now towards the high teens, sort of 17, 18% of Canadians are reporting problematic cannabis use. It's about 1 in 6 young Canadians now use cannabis on a daily basis. There's more people using cannabis on a daily basis in the United States than there are drinking on a daily basis. I don't think it's a wise path to send our kids down, because it probably won't be us who's heading down if it is legalised. Talking about kids, one of the consequences of legalisation has been the entrepreneurs move in, they diversify products, and for reasons only known to themselves, they've decided to make the edible cannabis products look like Haribos, which then unsurprisingly some kids actually think are Haribos and they consume them. So there's a big rise in poisoning presentations by oftentimes young children who usually don't know what they're consuming, ending up in emergency departments. That diversification of products has also extended into the vape market. So we now have THC vapes as well as the edible products. And then we also have, I suppose over the last 20 years, there's been a bunch of other chemicals identified that act on the CB1 receptor, which are completely unrelated chemically to THC, the active drug within cannabis, but they act on the same receptor. And those synthetics are sometimes they're put into vapes, sometimes they're sprayed on dried vegetation and then smoked, and they give a cannabis type effect. And we encountered that in Ireland, if people recall, back in 2010 with the head shops. Products like XXX and Spice and so on were being widely used at that stage and causing lots of both addiction issues and mental health problems. So the synthetics are there as well. Just to touch on other drugs, I suppose, that are of relevance to adolescents at the moment. Nitrous oxide deserves a mention. It's hard to figure out why drugs become fashionable at different times. Nitrous oxide has been around for decades. It's the active drug that's in gas and air that women might use, during labour for slight analgesic effect. It's also the gas that's in your. You've got to buy a can of these cans of whipped cream that you get from the fridge. You just spray it on top of your dessert. It's nitrous oxide is in that can, which is why sometimes the small little silver bullet-sized containers of nitrous oxide are called whippets, because that's what they're originally designed for. But whether nitrous oxide is sourced from one of those small little whippets or from a larger canister, it tends to then, if it's been used by a young person for intoxication purposes, it's then transferred into a balloon, the balloon's inhaled, and it gives a brief, intense intoxication that lasts 2 or 3 minutes really, and it's quite like just been very, very drunk very, very quickly. But after 2 or 3 minutes, because it's a volatile gas, you quickly exits your body and you're sober again, but you'll repeat. And people can repeat sort of endlessly over a period of hours, and that leaves them vulnerable to accident and injury. The can that they're sourcing the gas from, if people remember their physics and the latent heat of vaporization, it just gets colder and colder and colder, and because they're sort of semi-comatose via the nitrous oxide, they don't notice how cold it's getting, and people are getting real serious frostbite, sometimes full skin thickness injuries, by having this canister of increasingly freezing nitrous oxide between their legs. There's also concerns about spinal injury, damage to leaving people with sort of peripheral neuropathies and so on. Actually, the other drug, top right, is ketamine. Again, another drug that's been around for decades, is occasionally used in emergency departments. It's a really useful, has anesthetic type properties. And it's become really popular on the sort of the party scene, the nighttime economy, at festivals and so on as well. Why it's become fashionable now as opposed to 5 years ago or 10 years ago, I don't know. Cocaine certainly deserves mention. So this is a graph there on the right hand side which looks at cocaine-related hospitalizations in Ireland over the years from 2000 to 2024, and it's pretty much a mirror image of the house prices in Ireland over the last 25 years as well. So during the Celtic Tiger years, everyone had lots of money in their pockets, and some people chose to spend that money buying coke, because coke is an expensive drug. During the years of austerity, coke use declined, medical presentations linked to its use declined. But as house prices and the economy began to pick up around 2011-12, coke use has begun to increase as well. So it's now become a significant issue, and certainly for young people in their mid to late 20s, cocaine is the #1 drug problem of the moment. And that's very different from 25 years ago, when it was really sort of socially disapproved of in Ireland, perhaps as it still should be. In terms of drug-related psychiatric admissions, the data on drug-related psychiatric admissions is a little bit tricky to interrogate. First of all, I was a bit surprised to see that 1 in 8 of all psychiatric admissions actually have an alcohol or drug-related diagnosis in Ireland, and that's as high as about 1 in 7 for people in the 15 to 34-year-old age range. Not necessarily almost the primary diagnosis, but it is that high. An awful lot of those, though, have this F19 code, which just says polysubstance use. And for those of you who are psychiatrists, I'd ask you, please don't put down F19. Tell us what drugs were involved. It's useful to see which individual drugs contributed to the presentation. But when you do look at the data on where people have specified the individual substance, for those drug-related psychiatric admissions, again, the most common one are the cannabinoids. And I say cannabinoids now. 2 or 3 years ago I would have said cannabis, but because of HHC and its role in admissions 2023, 2024, it certainly is contributing to some of these. But it's certainly way ahead of cocaine. So even though cocaine-related presentations have increased, cannabis from a mental health point of view is the drug of concern. In terms of the drug-induced psychosis issue, I guess, for those of you who encounter young people, maybe in emergency departments and there's some drug use, I suppose all I'd sort of say is that the key thing to try and figure out, and you might require collateral to figure it out, is when were the drugs actually consumed? Because I guess the number one question for yourself is, okay, one, you're assessing symptoms, and are there psychotic sort of symptoms here? Are there delusions and hallucinations and so on? But if drug use was a few hours ago, I don't think it's sort of fair to call that a drug-induced psychosis. I think that's an intoxication-related event, and you'd hope within 24, 48 hours, intoxication passes and the person is well again. Where symptoms persist beyond 24, 48 hours, then it's more reasonable to view it as perhaps a substance-induced psychosis. And we know that certainly drugs like cannabis and cocaine have that potential. They also, for people with pre-existing illnesses, pre-existing psychotic illnesses can certainly bring on relapses. And there's also, I guess, for people who are physically dependent on drugs like alcohol and benzos, in withdrawal states, they can have psychotic type symptoms, but again, that's usually in the context of a confusional state, so it's not, again, really a psychosis, even though to the untrained eye, it might look like that. So again, this is partly trying to explain why I focus so much on cannabis and cocaine, I suppose. So if you look at addiction treatment presentations in Ireland, this is data from 2024. What was the primary substance? So 1/3 of cases, it's cannabis, or a bit more than that. A bit over a quarter are cocaine, and then there's a hodgepodge of substances. Alcohol is only a bit less than 1 in 5 presentations in that age range. If you went down a little bit further to under 18s, it would be I suppose more like 60-70% cannabis, maybe 20% HHC, and 2 or 3% cocaine. Cocaine is an expensive drug, so under 18s aren't using that much of it. So the bulk of these presentations in the under 25s are in that sort of 20 to 25-year-old age range. Good news as well is if you look at the left-hand side, there are heroin and other opioids, and reminding ourselves of what a mess North America is in. The number of heroin-related presentations has fallen off a cliff, fortunately, in the last 20 years. My job was created in 2003 because of the tail end of the heroin epidemic that was having spillover effects into adolescence. I haven't had a young person in front of me under 18 with a primary heroin problem in a decade. And I think it's important probably to say that, because we can get a bit hopeless and nihilistic about drugs and drug use and drug policy. We're endlessly told it's not working, it's all just pointless, why don't we just give up? Heroin was a phenomenal problem in this city back in the mid-1990s. And many people continue to pay a price for the problems that they developed at that time. But, we should be proud of and pay more attention to the success we had in addressing that horrendous problem. And we turned the ship around, and we've created a society that young people don't go down that particular path, certainly. And again, we shouldn't take that for granted when we look at North America, where they pursued other policies. They had less cautious prescribers of drugs like OxyContin, and their opioid problem just morphed from a heroin problem into an OxyContin problem, and more recently then into a fentanyl problem. So much as I hate cannabis, I suppose, and because it generates so much of my work, I suppose I'd much rather deal with teenagers who are struggling with cannabis than struggling with heroin. So for those of you who work with young people, generally, I suppose it's important to be curious about their relationship with substances, and in terms of the questions to ask, it's, do you drink, do you smoke, or vape? And if they're smoking or vaping, you then want to interrogate that a little bit as to what it is that they're actually smoking or vaping. There's no point asking someone to use drugs, because, if they're using HHC, they say, no, I don't use drugs because HHC isn't a drug. As far as they're concerned, it's a vape. Or even cannabis, they mightn't view as a drug because, it's cannabis. It belongs in their head in a different category to drugs. So to just ask a more general question about whether or not they use anything to get high, stoned, or intoxicated, or to self-medicate, to help get them through the day. And if yes, then to sort of begin probing to see if you can figure out what exactly it is that they're using. And you know, and don't just certainly if you're not pressed for time and you meet a young person who says they don't use cannabis or coke, you could just go, okay, that's brilliant. But I think you're better off maybe asking the next question, which is, have they ever been in situations where they could have used and they chose not to? And what informed or influenced that decision? And that might be an opportunity for a bit of psychoeducation. You might just consolidate what their already established beliefs or add some additional reasons to remind them why that was a wise and positive decision, because they're likely to be in that sort of situation again. In terms of diagnosis, I like the substance use disorder concept as opposed to the addiction concept, particularly again for adolescents. And for me, a substance use disorder is that where someone's relationship with a substance has become problematic. The substance is now more in control of them than they are in control of it, is the way I'm inclined to conceptualize it. In terms of addiction treatment, we've looked at the new dual diagnosis model of care has been rolled out nationally. We're one of the pilot sites for adolescents. The plan, I suppose, across dual diagnosis treatment has been to move away from this scenario, the Mexican standoff that we used to have between addiction services and mental health services, where each one looking at the other, but both sort of not really wanting to be involved or saying this patient isn't ours. You need to go away and get your addiction fixed and then come back to us and we look at your mental health, or vice versa. Or you're too crazy for us. We can't manage you. Get your mental health fixed, because you need to be really well to participate in our treatment program. So, you know, we need to work with people where they're at, which is having two problems simultaneously, and have services that are capable of doing that. So we have this multidisciplinary team. And for me, it's very much about the team. Psychiatry, psychiatrists, and so on, I think we play an important role in assessing the dual diagnosis piece. But it is the multidisciplinary team who really arrive with a strong set of psychosocial skills that form the core part of the treatment intervention. And again, hence the last slide there, that just reminds you why I hate cannabis so much. Okay, it's dominating, it's the main drug in so many of our referrals. One of the challenges you get with adolescents are usually brought into treatment by their parents. Most adult addiction services will insist that the person self-refers. So if they're self-referring, you've got a customer in the room with you at day one because they've self-referred. We tend not to have a customer in the room with us at day one. So our challenge on day one is to make sure day two happens. So we're trying to build some sort of connection with the teenager, help them begin a conversation about their relationship with the substance, why it is the adults around them might be worried, to help them think about that, so we can begin generating a plan from there about how we might get the adults off their back in terms of potentially addressing their substance use. Equally, like this young lady here, they might be very keen on addressing one problem, but not so keen on addressing the others. And I guess our view is you push the open door, you work with where the motivation is at the beginning, and then maybe park the conversation about the issue that maybe you're encountering more resistance, certainly on day one, but obviously park it in your head and plan to revisit it. And family is just terribly key to our thinking about treatment. Where parents are actively involved in a young person's treatment, we know they do well, and we have family therapists on all of our teams. So Fiona's hovering. So I better wrap up. Okay. Can I have 2 more minutes? Great. So family is really key. One of the issues, as I mentioned, particularly with cannabis, been a main driver of referrals. And this issue, I think, with a lot of teenage boys dipping in and out of cannabis withdrawals, with a lot of that irritability, like what we would call child-to-parent violence is a really, really common problem. And it's the most common issue that parents bring to us. It's just the walking on eggshells in their own home, the anger that they're dealing with. So non-violent resistance has become a core sort of component of the treatment response that we provide to families in such cases. The other treatments are largely, as Colin sort of said, talk therapies, motivational interviewing, CBT, and so on, and addressing comorbid issues as they crop up. While accepting that that can be challenging to assess those comorbid mental health problems in the presence of pretty active substance use. But you're certainly trying to do so, and you're trying to weigh up the pros and cons where you do suspect a comorbid mental health problem about the possible role for medication or not. And we certainly prescribe a little bit, and many of our patients, probably as many of a third of our patients, are simultaneously open to CAMs, who are often prescribing as well. And I think we each appreciate the presence of the other. I think it's reassuring to CAMs to know we're involved keeping an eye on the substance use, and maybe allows CAMs teams provide treatment, including medication, for longer than they would otherwise. And equally, us knowing that should the mental health issues really escalate and get very, very messy, having the CAMS team in the background is reassuring to us. So it's about services working better and more together, I suppose. I'll stop there. Thank you.
Wow.